I'm Jerry Keusch. I'm at Boston University, and I've had the privilege of chairing our local organizing committee for the meeting, which has been extremely successful and exciting and interesting. But nothing is more interesting than today's major sessions. The plenary panel this morning with an unbelievable, stellar group of global leaders picking one problem to address. And because we basically know what the problems are, we just don't know what the solutions need to be. We've asked them to do two things that are very difficult. The easy part is to ask them to state a problem in less than a minute, because the longer they take, the less they have to try to solve it. And then in less than 9 additional minutes, come up with a couple of ideas that would really be in the category of big idea that we could try to implement. And so I'll invite the panelists to come up in a moment. The other thing I think that we tried to do this year was to be a bit innovative, if we could, and particularly thinking about the future, and the future is the young people. So we paid attention to our trainees and our students. We had some very successful Meet the Plenary speaker sessions with a small group of young people in the field, and that went exceedingly well. We have a bunch of undergraduates from institutions around Boston who are here this morning. And especially, we've invited a group of kids from high school who are interested in science, aware of the fact that there is a world outside of the world that they live in here. And if I may have that first slide, I just want to go through this just to recognize this group of kids who are coming with their, generally their science teacher, to spend the day with us. So this is a group from Katz Academy, the next one. The O'Brien School of Math and Science, which is a science high school here in Boston. Next one. Boston University Academy, the next one. The River School, next one. Madison Park Technical Vocational High School, and finally, a group of kids from Worcester. So I would like to give them a round of applause. You guys are the future, and we're really delighted to have you here. And in connection with that, I would like to thank several colleagues who helped us connect with the schools and invite these young stars. Valeda Britton and Jameel Idiokikis. Valeda's over there, and Jameel I saw with his son over here. And Catherine Lizariaga and her team at the University of Massachusetts Medical School in Worcester. And I would also like to pay special thanks to the Sheraton, which has provided some assistance and a lunch for our high school guests today. So thank you, Sheraton, for being participatory in setting this up. I would like to invite our panelists to come up and make yourself comfortable and have a seat while I'm continuing to talk. So come on up, and we'll introduce you one by one as we get started with you. The idea for the panel this morning was that, as I said, we know the problems all too well, but we don't really know the solutions, and we have not. We've not really let our creative juices flow and try to take ourselves out of our comfort zone and do something unique and interesting. So we assembled a group of folks who are deep thinkers, and we ask them to let their inhibitions go and think as creatively as they possibly could. That's a real challenge, especially when we said 10 minutes or less. And so we figured we needed 2 moderators for this session to herd this group of cats. And so Keith Martin and I will try to keep things on time because we really wanted to leave a fair amount of time for some conversation with you in the audience and among the group of our panelists. So we hope it's going to work. With this group, it can't possibly do anything but work exceptionally well. And we'll just very briefly introduce them one by one as it's their turn. I asked Victor Dzau to start. All the bios, all their bios in detail, I could use up the entire 2 hours to introduce this group. So I'm just going to give, for the first couple that I introduced, just a very brief thumbnail. Victor Dzau, I got to know when he was the chairman of the Department of Medicine at the Brigham. He was creating a global health program. He had a couple of young guys at the time who seemed to be interested in global health. One of them was a man named Paul Farrar, who is here, and the other is a man named Jim Kim, who is now the president of the World Bank. So not too bad in selection of protégés, Victor. Victor moved on from Harvard to Duke, and he created and expanded the global health programs at Duke in an extraordinary manner. And then more recently, it must have been July of last year, Victor became the president of the Institute of Medicine at the National Academies in Washington, D.C. And so I've asked Victor to come and present a problem and some big ideas on how they might deal with it. So, Victor.
You want me to go first?
Yes, please.
Okay. Well, thank you, Jerry. It's really a great honor for me to be here, particularly with this panel of distinguished global health leaders. Certainly, I feel very privileged to be among them, and I look forward to hearing from them. I still remember the first meeting you called before the formation of the CUGH in Boston. This is when I first arrived at Duke. This is about 8 years ago, I think. And the whole concept of global health in universities. We were just about to launch an institute at Duke, and look at this today. Just congratulations, wonderful. Okay, so at IOM, I think about big issues that affect the globe and also U.S. And of course, the one that's preoccupation for me and for all of us is the Ebola situation. So if you look at Ebola as a wake-up call, I would say the big problem is lack of preparedness for global health infectious disease threats, for pandemics, and for medical catastrophes. And so if you look at what's happened in Ebola, where some 24,000 reported cases, over 10,000 deaths, and the catastrophic economic, social, and health impact is quite amazing. We all know that there's so much written about how could we have done better. The fact that the first case was first reported in March, and the ministerial meeting was, I think, in June, and then the emergency was called by WHO in August, and US finally mobilized in September, and this delay was too long. But I think when we think about the problems, we think about, at all levels, failures. As our good friend Jim Kim said, it's actually a failure of the institutional, international community. So if you look at international, really poorly coordinated, very slow response, lack of leadership and clarity of accountability, and of course, no emergency funds. You look at the country level, there's failure of traditional surveillance, failure of weak public health, healthcare. I'm sure there's a lot going to be talked about these fragile countries where really these things have been broken down and not rebuilt, and of course workforce, and ultimately lack of healthcare facilities. And the community level, a trust issue, a breakdown in trust, but also greatly a lack of information and understanding the cultural sensitivity and information of disease in rural areas. So the big idea is actually to create a global health risk or security framework. This is one that brings together all the stakeholders to say, how can we prevent this in the future? How can we better prepare? How can we effectively and quickly mobilize resources and leadership for the next huge disaster, outbreak? And I think in those contexts, we have to think about leadership and governance. We have to think about coordination of responses. There's a lot of discussion about the fact that this is totally uncoordinated. And we have to talk about mobilization of resources, workforce, and money. One has to think about how to have an effective surveillance system, tracking, reporting, and a good database that is real-time and being shared. How do you think about much faster point-of-care diagnosis and countermeasures, vaccines and drugs, but also a resilient health system that connects public health with healthcare delivery, that strengthens so that at the end of every disaster, we not just came in and just kind of address disaster, but create a long-term system. And of course, financing. This is a big issue, as you all know. Even when World Bank released $500,000, it was not able to reach for months to the front line. And we think about much bigger. Right now, it's looking like $5 billion worth of commitment of dollars. One thinks about much larger. How do you do that financing? And of course, we heard from a lot from private sector the fact that they were trying to help. UPS companies were trying to help, but they didn't know who to go to, whatever. And Paul was leading the Haiti response. I saw that happening, and the coordination. So we haven't learned a lot in terms of how we can, in this time, how can we do this in the future. So the big idea is to create a framework, and the good news is that from a conversation with Jim Kim back in the fall and with Margaret Chan, we begin to work towards such an idea. The long and short of it, I would say, is with the help of Jeremy Farrar, also Gates Foundation, Rockefeller, USAID, and Ford, we now have an international oversight group, and we're going to commission an international group that looks at 4 work streams: governance, financing, health system strengthening, and research and product development. All these 4 work streams are going to work taking deep dive issues about IHR, about regulation, about governance, and about the role of WHO and others to how do we get finance, capital markets, and also reinsurance company involved. Because the reinsurance is one way to create that big pot of dollars. And how do you create several layers of financing to allow triggering of moves of dollars very quickly. And of course, taking a deep dive and creating a resilient health system with public health, traditional public health all the way to healthcare delivery. And Paul can tell you many stories about the fact that really, if healthcare was done right with rehydration, et cetera, a lot of people would have lived. And finally, we recognize the importance of countermeasures, vaccines, drugs. The fact that many of these are developed by the private sector, they need to be part of the equation. They need to be incentivized, and the government needs to figure out a way to have them take that risk in order to mobilize these things quickly. So this commission will have 4 work streams, and I know that many people on this panel will be asking to help. And in fact, this work stream will work throughout the summer so that each work stream will have a workshop report, and then the commission is going to pull together the final report that is going to be useful, of course, in helping to move forward. We are in coordination with the UN panel. We are in coordination with the G7 conversation. Just last week we had, there was a meeting in which we now also connected. And we hope that all this has been said by many people who's been supporting this as a very important, independent, comprehensive framework of experts that can be helpful to UN, helpful to the globe as a whole in better preparedness for the future. So that's the big idea. Thank you.
Under 10 minutes, excellent. I'm not going to necessarily go in the order that people are sitting here, but I will ask the mic go to Julio Frenk next. Julio is currently the dean of the Harvard Chan School of Public Health, but I've known him for a long time. Before, when he was the dean of the first School of Public Health in Mexico, continuing on to when he was one of the Associate Director Generals at WHO, and on to the Ministry of Health, as the Minister of Health back in Mexico. He has a long and distinguished career, but I'm going to stop there in terms of the introduction, because what we asked him to come and talk to us about was a recent report a year ago from the Lancet Commission on Investing in Health. And what Victor just talked about is another major commission, another major report, and we're all aware of the need to translate reports into action. And so we're now a year after the report was interested, and I'm kind of curious to know what's happened.
Good morning to everyone, and thank you, Jerry, for the invitation. Thank you also to Keith Martin for inviting me to participate here. And yes, a year ago, this report was released. The report of this Lancet Commission on Investing in Health was motivated by a emblematic anniversary, the 20th anniversary of the World Bank's flagship publication, the World Development Report of 1993, which was devoted to investing in health. That itself is a very big idea, the idea that health is not just an item of expenditure, but it's actually an investment that can help the economy grow, in addition to helping the health the health and well-being of people. That report changed the conversation because it was addressed to ministers of finance. I think it had a huge impact. Bill Gates has said that what motivated him to direct his philanthropy to global health was reading that report. It was hugely influential. So we thought that on the 20th anniversary it was a good idea to take stock of what had happened, and this Lancet Commission on Investing in Health was created. Larry Summers was the chair. Dean Jamieson, who's been active in the conference, was the co-chair, and there were 25 commissioners. I was fortunate to be one of them. The report on Health 2035 and health converging within a generation starts by, I think, facts that we all know. These 20 years are not just any 20 years, are 20 years of momentous change. On the economic front, huge progress. In 1990, about 60% of the world population lived in low-income countries. Today, 2/3 of the world population live in middle-income countries. So a huge movement in economic growth across the world. However, and this is the big problem, enormous disparities persist. So the problem is, how come in the context of huge economic progress, certainly of enormous political will as expressed by the MDGs, we still have these ongoing inequities around the world? And of the many ideas of the report, since we were asked to be very succinct, I like to underscore two fundamental ideas. The first is the idea of a grand convergence that I think has resonated deeply. And the second is the idea of progressive universalism, a progressive path towards universal health coverage. And just let me spend a minute in each of them to stay within my 10 minutes. On the grand convergence, with very detailed and sophisticated calculations, the Commission concludes that in our lifetime, within a generation, we can see a convergence in the levels of health for the unfinished agenda of all the low and middle-income countries, convergence towards the level of the best performing middle-income countries today. So this is not setting a benchmark of high-income countries, but the best performing countries, the famous Cs, the 3 Cs of Latin America, Cuba, Costa Rica, Chile. That is achievable within our generation. It requires a huge commitment to finishing the unfinished agenda. As we know, we have been since World War II immersed in the most tense and intense health transition in human history. It's not just been the growth in life expectancy, but it's been the fundamental shift in the nature of the causes of ill health. And so that today we really have a double burden of disease around the world, the unfinished agenda of common infections, reproductive health problems, particularly maternal and neonatal mortality, and undernutrition. Without having solved that, most countries in the world are facing now the growing threat of non-communicable diseases and the scourge of injury, whether it's due to violence or to so-called accidents. On top of that, by the way, we have now a triple burden, because layering on top of that whole double burden, we have the sort of threats that Victor was just referring about. Health threats directly linked to globalization that affect all countries, no matter what their level of income. Pandemics, the health consequences of climate change. So we have never had such a complex picture in history. Within that complexity, making sure that we finish the unfinished agenda so that we can focus attention on the other two big sources of burdens, the non-communicable diseases, the injuries, the mental health, and the global threats, becomes an imperative. And I think a year after, the notion of convergence, I think, has had a major influence in thinking about the post-2015 agenda, in making sure that at the top of the 2015 is to finish the unfinished business of reproductive health, common infections, undernutrition. MDGs 4, 5, and 6 continue to be top of the priorities, and that we don't lose that focus, because we have made enormous progress on those. We just need to complete that. As it turns out, most of the financing from now to 2035 or 2030 will come from domestic sources. And even though we like to stress how much international development assistance for health has grown, the fact is that health expenditures in developing countries, in low and middle income countries, has grown even faster than international transfers. And almost unavoidably, as income per capita grows, countries will continue to expand their health investments. And that makes it essential that we pay attention to the policies that will allow those countries to direct those growing investments in health towards, in a good way. And that leads to the second big idea. Everyone is talking about universal health coverage, and we all know about the famous CUGH that includes covered populations, covered diseases, and financial protection, percentage of costs that are covered through some mechanism of public financing. Davidson-Watkin has proposed what he calls the notion of progressive universalism. The fact that you explicitly begin with the poorest segments of the population, you begin coverage in that way. You begin by covering those diseases that affect the poorest, and progressively expand the number of diseases, and you begin by protecting the poorest families from the financial consequences of spending in health. I am proud to say that one of the prominent examples highlighted in the report is the example of Mexico, where we launched a scheme called Seguro Popular, or People's Health Insurance, to protect half of the population that was uninsured, 50 million people, who happened to be the poorest of the poor. And explicitly in the law, it was written that coverage had to start with the poorest, with rural areas, and with indigenous communities. And that actually did happen. And from the get-go, the unfinished agenda was prominent among the package of interventions, which was expanded so that now it also includes, in a very comprehensive way, cancer, diabetes, heart disease, mental illness, etc. So it is possible. There are examples of where this is possible. Central among those elements of protection are the sort of resilient health systems that I think the Ebola epidemic just underscores the need to focus attention, both in dealing with the epidemiologic surveillance that is required, the public health side of the health system. This is not separate from the health system. The public health side, the public goods that are produced by any health system are absolutely crucial. And that's part of the notion of a progressive universalism, making sure that that common basis of community health services, of epidemiologic surveillance, of preventive services is from the beginning covered for everyone, including the poorest groups of the population. To do all of that, we will need to fuel a new generation of investments in research, and that obviously resonates with the topic of this year's CUGH conference, mobilizing research. So the report ends by making a call to redoubling our efforts for investing in international collective action. The big failure of Ebola is that we have failed to invest in global public goods, knowledge-related global public goods. And that starts with research, and the report actually, I don't have time to go over that, but actually proposes an agenda on product development around vaccines, drugs, and diagnostics that obviously would serve us well, especially where there is a market failure, like in the case of Ebola, where market mechanisms will not provide the R&D required for vaccine, drug, and diagnostic development, and in the sort of surveillance mechanisms that are the quintessential international or global public goods. So that's a third big idea that I would add. So in summary, investing in health, this is an investment. A grand convergence possible if we don't take our eye off the priority of finishing the unfinished agenda, a progressive path towards universal health coverage, progressive universalism, and a commitment to fund global public goods, knowledge-related global public goods at the level that the complexity of our world demands.
Thank you, Julio. And for the Harvard students who are here, I'd point out that the dean does take instructions. He was just about up to the 10 minutes. So thank you, Julio. And he'll listen to you. Julio's comment at the end about the research component of the agenda of investing in health is exceedingly important. So I'm going to ask next that Jeremy Farrar pick up the microphone. I met Jeremy about 25 years ago in Saigon. He was a young guy then, leading, he's still pretty young. He was leading a team from Oxford that had developed a collaboration. It was funded by the Wellcome Trust, and I was part of a visiting team to do an evaluation. And I was blown away with what I saw. Jeremy has had a very distinguished career in science and public health and in the field. And he has recently returned to London as the director of the Wellcome Trust. And it is so important for our community to have somebody in that position who's been there in the trenches, has done research in the laboratory, has worked in the field, and understands the dimensions of it. So, Jeremy.
Thanks very much, Jerry. It's going to take me 25 years to work out how to explain to Americans that my surname is Farrar, not Farrar. But
I thought it was
I'll not hold that between you and I, Jerry. So, in 10 minutes, I'm actually going to build on some of the things Victor said, but I'm going to argue actually in the context of epidemics and in global health generally that one of the things we have to break down is the compartmentalization of the way we approach global health and using epidemics as a reason for that. Firstly, epidemics are not rare. They occur on a very regular basis, either at a national, regional, or global level. They often only come to the attention of the developed and Western world when it hits the newspapers or individuals return from those places. But the reality is they're happening all the time. WHO itself receives almost 400 reports a year of credible epidemics that are occurring at a national level. And that is only likely to increase in the future for a number of reasons. The changing environment, drives to urbanization, land use, and the way that, as a result of those changes, societies themselves change, both in the way they travel and in the way that individuals and their families act when they're living in big urban centres, is distinct, and it's something we don't understand about the way people within cities live and respond to authorities and health systems in a way that rural populations do not. The increasing encroachment and changing nature of the habitat between human and animals obviously raises increased risks of transmission between those two. And we still do not understand sufficiently the biology of many of these events to know that as we increase surveillance globally, and therefore increase the number of reports that we find, we don't understand enough of the underlying biology to understand which of those are important and which may be less important. And we understand even less of the social sciences, anthropology and others, of the drivers of those events. The idea that there are a certain number of countries with fragile health systems, I think, is also a misunderstanding. Every country in the world, if it actually has a relatively fragile healthcare system, even sitting here in the richest country in the world, you would struggle if you had some of the events that happen in some parts of the world at certain times. Many of you may not have that much great respect for the National Health Service in the UK, and I may or may not share those thoughts with you. But in the middle of the winter of 2010, there were 115% bed occupancy as relation to the pandemic flu. Even some of the richest countries in the world would struggle. So fragile healthcare systems are a relative term, and there are certainly some more fragile than others, but all would struggle with the sorts of extra demands placed on them. And many parts of the lower middle income countries are struggling with a combination of factors which the so-called developed world has not had to struggle with in quite the same way. So although the US, Europe, Japan, many countries were able to reduce the burden of disease related to infectious diseases as the rise in the non-communicable diseases came, many parts of the world are struggling with both of those at the same time. And the healthcare systems that are required for those may look quite different. And yet we're tending to build systems and compartmentalise health into deal with one, but not necessarily the other. Better and smarter surveillance is required globally, and I have been quoted as saying that surveillance is not the actual answer to the question. There is no doubt that better surveillance, smarter surveillance, and surveillance that can be sustained is absolutely crucial to the future of global health. And that doesn't just relate to infectious diseases. Surveillance for the so-called non-communicable diseases is just as important as it is for the communicable diseases. But we should not think that calling for greater surveillance will be the issue that responds. Surveillance will identify things. If we don't build a more resilient structure to then act on the basis of that surveillance that we identify, then the surveillance itself is only of limited value. So smart surveillance has to go along with the willingness and ability to act, and that requires robust healthcare systems and a workforce and capacity to respond to them. Ultimately, that also depends on the global governance of health. And many of the global governance structures that we have, whether we're talking about the global structures that were put in place to deal with the financial crises, for instance in 2000, 2007, 2008, or indeed global health, were structures established in the 1940s. There are not that many organizations established in the 1940s and 50s which have not been reformed and which are still capable of responding to the modern world. And I think the structures that were put in place for very good reasons in the 40s and 50s need reform in order to cope with the challenges of the 21st century. But I am a very, very strong believer in the need for global structures. Countries at various times in their history, all countries will go through various political decisions to either become a more global player or, and so all countries do this, including my own country, including the United States, will at times, for its own political reasons, wish to withdraw from that global perspective. And we cannot allow global health of such importance to be driven by the narrow political decisions that individual countries make. So global structures are absolutely critical, but they should be kept up to date and they should be reformed where appropriate to meet the challenges that we will face in the 21st century. And they need a mandate to act. And that means that narrow national causes sometimes have to be put aside for the greater global good. And we're all going to have to learn to live with that and reduce some of our power. And that is difficult, potentially, when you're the most powerful country on earth, to give up some of that autonomy to contribute to that greater global good. We also need to fund it, and we also need to provide the leadership of that organisation with not only the mandate but the support to deliver and be held accountable for the decisions they reach. In the 21st century, we also should not, in my view, compartmentalise these different perspectives: public health, clinical medicine, disease-specific, syndrome-specific or geographically specific. We should not say that the answer lies in delivery of classic public health, or that there's a magic bullet to answer every problem, whether drugs, diagnostics, vaccines. One of the causes and the reasons why the Ebola crisis in West Africa has been driven as it is because we haven't understood, as a region or as a globe, the social sciences and the social drivers and the social determinants of health sufficient that we're able to deliver the sorts of interventions that are required. And I have a concern that and the universities have a critical role to play in this, if we increasingly compartmentalise the way we educate young people and we put them into various streams too early, then the various ologies that we are defining will not learn each other's language and will not be able to communicate with each other. And I think that is a great worry for the future and something we must guard against. The regulatory pathway we could come back to talk about, but we cannot have a system which requires response times in years. We have to be able to respond in days and weeks to these events as they occur. And the final comment I'll make is none of this works unless you're able to build the trust between individuals and between communities and between countries that allow these sorts of events to be dealt with in a coordinated way. And something like CUGH, which is bringing together young people, ultimately trust comes from connectivity between people. And if the next generation of leaders of global health are encouraged and facilitated come together in the sort of forum of CUGH, then I have much greater optimism than I did during my own generation's education. Thank you.
Chris, if you would take up the microphone next. Chris Wilson, I've known Chris for a little over a decade in connection with the very first of the grand challenge ideas in global health. I think the first grand challenge since the mathematics grand challenges of the 19th century. And that's become a big idea that everybody is doing. Chris has a distinguished career in academia and in product development, but for the last 10 years maybe, 6, has led the discovery program at the Gates Foundation. Chris Wilson, thank you.
Well, thanks, Jerry, for giving me this opportunity and the foundation opportunity to participate in this forum. So I think I'll give a little bit of a background history, which you alluded to, Jerry, and then maybe cut to what I think is a new example of a problem that we're struggling with and hope to have collaboration from people in this room on. So the foundation's 15 years old, and it was founded on the notion, the Bill and Melinda Gates Foundation, that is, on the notion that all lives have equal value. And these goals continue to guide the work of the foundation at the present time. Now, soon after the founding, it was recognized that, although important, the deployment of tools that were available at that time, products and solutions, in low and middle income countries was simply insufficient to really address those goals in the way that we would like to. And that if those goals were to be met or approached, that new discoveries and their translation into new solutions to meet unmet global health needs would be required. And those really came in several flavors. One is, there might be a perfectly useful product, but it's not practical, affordable, scalable, or deliverable under the circumstances in low and middle income countries, which often prevail. Examples would be things that require -80 freezer storage. That's going to be a hard thing to achieve. And obviously cost is a huge issue there. So there it's really trying to make a product that actually is suitable for those clients. Now, there are other situations where simply the world is looking for such a solution, and HIV vaccine would be an example of that. We'd love to have one, and a lot of money and effort is going into that. But there are many other such challenges that have yet to be met. And then finally, of course, there are situations altogether too common where we simply don't know enough to go about developing those new products in an intelligent way, or have the tools that would accelerate their development and make it practical to actually do so. So there, it's required to actually make some investment in that. And there we, of course, stand on the shoulders of larger funding agencies that support basic science. So about 10 years ago, as Jerry alluded to, this recognition of these unmet needs and new solution needs gave rise to a program that we and our partners, including Wellcome Trust on my left, named the Grand Challenges in Global Health, borrowing obviously from the mathematician who coined the term earlier. And we've had a decade of experience with that, and so I guess the question is, what have we learned? And there are a few things, and we've learned both from successes and plenty of failures, or let's say suboptimal performance on our part. One is that defining a challenge can galvanize the world's scientists and communities and other funders to address unmet needs. And so that seems to be, much like the X Prize galvanized people to try and launch something into space, it seems to have galvanized people around a set of important problems. Scientific creativity is absolutely essential. You need people who are creative thinkers. Creativity alone is not good enough. It must be crowdsourced from a broad diversity of people across scientific disciplines. We all too often work in scientific silos. We work in all kinds of other silos. So we really needed to access the world's thinkers. And over time, we and our colleagues and partners have gotten a bit better at this. And I think when we now issue calls, we get thousands of applications. And there's a lot of creativity out there in the world that wishes to address these kinds of problems. So taking advantage of that diversity of thinking by creating a vehicle that allows those individuals to get involved is important. And finally, constructive collaboration. This is basically a sine qua non. These problems are really big problems. And to think, it's not reasonable to think that an individual or an individual laboratory or an individual ology is going to be sufficient to address them. We need people who can think across disciplines. And that's the fun part of science anyway. You learn something you wouldn't otherwise. Bringing those collaborative teams together and having them truly be working on something that is greater than what they would be able to do themselves, and seeing that and being able to share in that is really important. Now, those things are essential, but they are not sufficient. The most common mistake that we have made has actually been the failure to adequately define the problem. If we've had scientists who addressed a problem productively and the problem that was defined was not adequately defined, that's a frustrating thing, because that's, if you will, if not wasted, it's misguided effort. And what I mean by not having defined the problem is something that in industry would be called start with the end in mind. You need to know the characteristics of the product that would actually be used by the clients to whom you aim to deliver it. And we're often pretty ignorant of some of those things, and we only learn by our mistakes. So what we need is to understand the real-world realities that make it difficult not only to take a discovery and translate it into a product, but to actually have the product hit the mark. You know, if Coca-Cola didn't know what people were going to buy and they went out to market it, they'd be out of business. We have the same challenge in global health. We actually have to hit the nail on the head. And so what's required, it would appear, and we are always trying to do better on this, is early and iterative and constructive input and co-development of problem calls, of definition of what is needed with those living in the communities which we hope to serve. Their public health agencies, their policymakers, because someone's got to eventually buy it and deliver it. And the political and scientific innovators and leaders in those communities are absolutely essential. I'm reminded of something that I've heard talked about in the lab, where I'd say a few months or a year working with those groups of constituencies can save you a couple of decades in the laboratory trying to develop a product. Because if you develop the wrong product, it's really a waste of all those resources. So let me just give an example of where I see a place where we can do better. And we're aiming to, and we're looking for help all the way. And I'll allude to an area that my colleague Peter Small is in the audience has been trying to drive for some time. And that's an epidemic that's been going on for centuries, and that's the TB epidemic, since a third of the world is still infected by that bacterium. And we continue to have lots of disease. And it's really a public health failure, but it also means the tools we have that allow public health agencies and more research-limited settings to function efficiently are less optimal than they could be. We still have to diagnose the disease either by inference, based on clinical symptoms in, let's say, a chest radiograph, or by a sputum diagnostic. And although we now have molecular sputum diagnostics, the magnitude of the impact they've had is, let's call it, less than we would hope. What's hard is you actually have to get people to cough up sputum. You have to collect that sputum, you have to analyze the sputum, you have to get a result back, and then you have to act on that result. What if we could diagnose tuberculosis with a finger prick blood or an exhaled breath? Well, we have people working on those sorts of solutions now. There's some encouraging data. The question is, can that actually be turned into a product? So that someone could show up at a clinic, have a finger prick, you could make a 90% probability diagnosis of TB, and then you could treat them. Now, that's the second part of the tough equation. Treatment of TB, frankly, has two problems. It takes too long, way too long. Imagine having to take pills for 4 to 6 months on a regular basis. That's really hard. And the second thing is that we're having trouble with drug resistance, right? So those are two important problems. How might we make some headway on that? I'm encouraged by the progress I'm seeing in the generation of natural products by synthetic mechanisms that weren't heretofore possible. You may have read a paper in Nature a few months ago where they isolated a new drug, which they showed is active to TB and is actually hard for the bug to develop resistance to. And that was done by isolating bacteria that could not be cultured, by isolating their nucleic acids and inferring the genetic information, the operons that went into synthesizing that antimicrobial. There are several related activities like that going on now that will allow us to discover new antimicrobials in ways that weren't heretofore possible because they'll be inferred by the genetic sequence. Moreover, a group at University of Illinois Champaign-Urbana have created a synthesizer of complex organic molecules that builds off the principle by which we synthesize peptides from individual amino acids, giving us the potential to synthesize these very complex, larger natural products the way we make typical organic synthesis compounds that underlie most of the drugs that are made in the world. So I think there's the opportunity to make a headway against this old killer of human beings by coming up with new agents that may shorten therapy, certainly will address some of the drug resistance problems, and a diagnostic that is not dependent on sputum. Those are the kinds of challenges and problems that seem worthwhile, but again, we need to continue defining what the target product profile of those things might be, so that if and when we develop those things, they actually are useful for people in the field. Thanks.
It's been fantastic so far, hasn't it? Great. So, good catch. Glenda, this is for you. When I was working in South Africa early in the 90s in a bush hospital, we started to see the scourge of HIV and the beginning of what has turned out to be the catastrophe we all know. Glenda Gray is the president of the South African Medical Research Council. She's a pediatrician and a researcher in her own right. But what you should perhaps talk to her about later on, if you have a chance, is the extraordinary and heroic struggle she and a few people made to be able to provide access to life-saving antiretrovirals at a time that politically was absolutely appalling. And to learn about that story, which is quite broad, have a chance to speak to her. It is inspiring, and it truly is global health and medicine at its best. So Dr. Gray, we are extraordinarily lucky that you have come from very far to be here, and the floor is yours.
Thanks very much. So I'm not going to be very global, so I apologize up front. I'm going to talk about local problems, and Jeremy, I'm going to be very narrow. I'm going to be country-specific. So I have local problems that may have global natures. And I would like to start off with saying that the health and wealth are inextricably linked. If you don't have a country that invests in health, you'll never have a wealthy country. And if poor countries don't invest in health research or in health and R&D, we'll always be poor, and we will always never ever have our own local agenda. And so for poor countries, the issue of making sure that our countries and our governments invest in science and technology and invest in health research is critical to address the problems that we have in our countries. So I run a science council in South Africa, and we're one of the few science councils in Africa that can fund medical research. And so I have a very limited budget, and my question or my problem is quite simple or quite large. So the problem that I have is that with my limited budget, I have to conduct and fund research that impacts on the lives of South Africans. I have to grow the next generation scientists and make sure that the pipeline of scientists in South Africa that address the South African needs are going. And not only do I have to fund that pipeline, I have to transform the way we do medical science in South Africa. So we have to transform who we fund and where we fund them. You know, transfer funding from white medical researchers to new black African researchers. We have to fund in rural areas, not in urban areas, and we have to go from the wealthy universities to the poor universities and fund research there. We have to create a new diverse group of scientists that reflect the diversity of our country, and we need to fund black women, and we have to fund in previously historically institutions. So that's the challenge that I have. We have to fund, because we have a limited budget, we fund the 10 most common causes of death in the country. We have the highest rate of HIV in the world, some of the staggering rates of TB. Not only do we have a huge burden of infectious diseases, but we have the highest rates of child murder and maternal and child health deaths. Maternal deaths and neonatal deaths. We have some of the highest rates of car accidents and head injuries. So when you have to fund research in a developing country, you have to address everything from infectious diseases to intimate partner violence to child murder and to non-communicable diseases. So it's a huge challenge with a small budget. And so we have to look at the innovation. So although we have a very little bit of money, we have to look at our problems through a local lens, and we have to look at local innovation to be able to address our country's needs. And we have managed to do that. So we have one of the highest numbers of people on antiretroviral treatment in the world. Almost 3 million people now in South Africa are on antiretrovirals. And by doing this, rolling it out just to 3 of the 5 million people we have who are HIV infected, we've managed to change life expectancy in 8 years from 57 to 63, which is a profound increase in life expectancy and hard to achieve in such a short time. So my question to the audience, and maybe to my big funders, my big brothers, the neighborhood bullies. How do I, with my limited funding, fund research in South Africa, in a developing world situation? How do I remain relevant, and how do we interact with the big funders and make sure that the local agenda is heard, and we find local solutions for our local problems? And there are ways of doing it, and I have learned of doing it, how to be innovative in funding, and obviously looking at leveraging funding, saying, I'll give you 1 million, I'll put 1 million down, and you put the other 1 million down, and let's try and work together to find local solutions. And then there comes the situation is that often in South Africa and in the developing world, we are expected to compete 1 for 1. I give you $1 and you give me $1. And is that a fair or an equitable way of financing health research? And I like the idea of the fairness index, that takes into account your situation when you do look at local funding. And I should be able to negotiate with the Wellcome or the Gates Foundation and say, I'll give you R1 and you give me $1 or a pound. And then we're really talking, good leverage. So I would love to leverage my R1 for your pound, Jeremy, and have a local context. But I guess the most important thing that we can do as poor countries is, besides leveraging our big brothers, is to make sure that we have a local funding, that we have a science vote, that we have an R&D vote, that our countries put money into the science vote, that we insist as citizens and as taxpayers that unless we're putting money into our own science, we will never have the solutions that work for us. And so even though I will continue to leverage my R1, I want to rather make sure that my country puts money into R&D and puts significant money into it. Because if we don't have a healthy country, we'll never have a wealthy country. And we have to take responsibility to make sure we are wealthy and healthy. And the best thing a country can do, particularly a poor country, is to invest in research and development. And that's what we should be doing as local people and as global people. So I'm going to finish now. I'm losing all my notes. Are you going to crib it? And as a check, that's great. So I'm going to end and say that maybe at a national level and an international level, the encouragement of countries, even poor countries, to invest in health science is one of the best things that we could do.
Thank you, Glenda. Paul, you're next. Dr. Paul Farrar is somebody some of you may know. He co-founded Partners in Health. He co-founded Partners in Health with an esteemed gentleman who is gainfully employed at the World Bank, I understand. But if you have a chance to look at which most of you know, I'm sure, the extraordinary work in Haiti, but also look at the phenomenal work and the leadership Paul and you and your team have done to deal with the Ebola outbreak taking place in West Africa. And the rapidity with which you have worked to deal with that is something that all of us here and around the world have learned from and we're deeply grateful for. And also your ability to articulate and communicate to the rest of the world and speak up for those who live lives of quiet desperation around the world and bring humanity to our profession of medicine. So thank you for doing this, and the floor is yours.
Thank you very much, and I must say I'm grateful to hear it, having just returned yesterday. And I was not actually going to talk about Ebola, but now I'd like to. I've talked about little else for the last year, but I instead of thinking about a big idea, just to tell a brief, as a 9-minute story about how big ideas can also fail and how they can be dangerous. You know, when we look back at the notion of cost-effective analysis, you know, the idea, and I'm sure Esther, see, I'm getting my props in, that I actually can pronounce people's names, Jeremy. Esther will address. That's actually not easy to evaluate costs of something, right? The cost of, for example, as Glenda just said, of not investing in health, and that includes, you know, as Jeremy said, as many people have said, that includes a wide range of activities, endeavors, right, from surveillance certainly, but also to progressive universalism. The cost of not doing it is very significant. So cost is hard. People conflate it with price, right? And then effectiveness. I mean, how could that be easy? We've been struggling with that for at least a century in medicine. Other fields have been struggling with it for longer. We're the youngest science, some say. So, and then analysis, critical analysis. We've just heard from every single one of the panelists that our analysis, like our action, is balkanized, siloed. So ideas can have negative consequences as well, big ideas. Then they can drive forward agendas that have to be abandoned when, in fact, some people don't have time, that kind of time for correcting course. So all that's been said already. I just would like to say that since the Flexion Report 100 years ago, the idea of medicine and public health was to link research to training to care delivery. And yet it seems to be, from this experience of the last year, that there are still these struggles between these aspects of our work. And so what Partners in Health, which is a tiny NGO compared to some of the other institutions we're talking about, was founded to link those three activities: research, training, and service delivery for people living in poverty, usually extreme poverty. And Jim and I, since Jim was mentioned, were lucky enough to train. There were many other co-founders, Ophelia Dalamo, she's here this morning, Tom White, who since passed away, and our Haitian co-workers, who of course all have names themselves. And we had people like Victor who encouraged us to do this. So we were lucky. But when we get to progressive universalism, whether you call it, as we did when we were young, 25, 30 years ago, a preferential option for the poor, which is what we called it, stealing a term from liberation theologians, that is that we should preferentially do, Julio said this, we should make sure that these services, whether they are research, because research is a service, as Glenda just said, and I will trade you Leones for Rand any day, okay? Because South Africa is the big brother on the block in my world. Lesotho, Malawi, I could go on. Or global health equity is, which many in this generation are comfortable with. But here's the narrative. So I never set foot in Sierra Leone until June, and when, thanks to a person in this room, Carmela Kletchen, we were able to bring together a group of surgeons to do another Lancet commission. And I'm quite skeptical about the dissociation between more studies and commissions and actual implementation. But that, I think, you already know. So people would actually say to me, wait, why are you an infectious disease doctor and anthropologist, I might add, Jeremy, an infectious disease doctor doing a surgery chairing or being a commissioner on a surgery commission? You're an infectious disease doctor. I mean, that's how ridiculous balkanization gets, or silos. It's like, well, it doesn't matter. This is not a conference about my personal training or my quest for personal efficacy. It's about unmet needs in really poor countries. Now, the place we chose, we launched this commission, John Mira and many other commissioners, Heidi DeBoss, there are people in this room who have helped to do this, launched it at Harvard, but the second meeting had to be held, we insisted, in a poor country without these kind of resources. And I confess in front of you, Glenda, that I said, and it can't be South Africa. And it can't be, and I didn't think that it should be Rwanda, where I had been living and working, because Rwanda has met so many of these health systems goals. And so, having worked with some British colleagues here in Boston who had gone to Sierra Leone, that's why we went to Sierra Leone for the second meeting. Now, as I said, I'd never been there before, but by May, it was clear that Ebola was spreading from the tri-zone area, in where Liberia meets Guinea, meets Sierra Leone. It's happened before. I can remember another zoonosis that jumped out of equatorial Africa to spread around the world. I think some of you in this room will know which one I'm talking about. And it was heading towards Freetown, which, when I went to Durban for the 2000 AIDS meeting, I got there and I thought, wow, this looks like Fort Lauderdale to me. Because I'm from Florida, you see. And I flew there from Peru because I work on TB. I won't go into the trajectory, but it wasn't easy. But the virus is heading towards, making this western surge across the region, right? From the rural areas to the urban areas. And so what happened next felt to me like a slow motion personal disaster and not an abstract experience. So first came the email saying maybe we shouldn't have the conference in Sierra Leone. And we said, no, you don't get Ebola from attending conferences. At least you shouldn't get Ebola from attending conferences. And everybody showed up. There were no cancellations. So you had 80 people working hard on addressing this problem of progressive universalism for the neglected diseases. By the way, everybody wants to be the neglected disease, right? But all pathologies affecting poor people are neglected, right? Trauma, for example, leading killer in Sierra Leone, just as in Rwanda, but there's no trauma surgeons, there's no trauma teams. So we had encouraged our friends to go into the public sector hospital and institutions, public sector being key to our discussion. As Julio will tell you and other people here, can't have progressive universalism without engagement of the public sector, the government. That doesn't mean the private sector can't be involved. Partners in Health is a private sector, NGO, by definition, non-governmental organization. Same for Harvard, same for the Brigham, right? So on the last day of the conference, I went to look at this Ebola preparedness effort from my friends, young people, and I only knew one Sierra Leonean infectious disease doctor who was an expert in, guess what, hemorrhagic fevers. And he was out there in Kenema, right, in harm's way, because if you look at the map between the east and the west, there's Kenema. And you had significant allies, NIH funding, American universities funding is going to come here to Harvard, to the Broad, this last fall. And I knew one surgeon who was there at the conference with us. And I went to this public hospital, which was a dump. No offense to your people, Jeremy, but you could have stuck around a little bit longer in Sierra Leone after independence. So this was, no, I'm kidding, come on. This is actually a very difficult story for me to tell personally, so that's why I'm adding in the humor, because it leads up to yesterday, and all in the 3 minutes that are remaining to me. But going into Connaught Hospital, and with the enthusiasm of these young British and one Spanish infectious disease doctor, also young, and I would say someone who lights up the room like a Christmas tree. She was there, and there were two nurses, and they said, here's our Ebola ward. So we walked into a room no larger, hardly larger than this stage, with 6 beds and sheets of plastic between them, and all their enthusiasm. And right across from this Ebola ward, not farther than from me to you, was what they called the A&E, the emergency room. And so clearly they did not have the staff, the safe space, or the systems to confront what was about to happen to them. And neither did Humar Khan in Kenema, right? He had research funding, but the district hospital in which he was working, the roof literally fell down around them. And I know this is a painful subject for other people in this room too. So in between the day that I left this conference, and when we started, and this is why I'm so grateful for your kind words, Keith. It was very difficult months because you don't say to an organization like Partners in Health, we have to make a major investment in West Africa when you're struggling every day to keep implementation in various countries going. So I think the big problem, big idea is we need more innovative ways of financing progressive, universal, and whatever you want to call it, for poor people. But in those months between the 20th of June, I left on the 19th, I think. I almost got kicked out off the plane, by the way, because I had a hemorrhage in my eye. And, you know, which you don't get Ebola in 3 hours either, right? So the, you know, this slow motion, again, our inability to respond, as Victor said. So all these people got picked off, you know. By July 29th, Umar Khan was dead, you know, never having left Eastern Sierra Leone or receiving, there had been no collision between modern medicine, whether we're talking about research, training, or service, that I could see. Maybe one tiny little ICU run by an NGO was really good. That was in Freetown. But both doctors at Kenema, more than half the nurses, and the nurses I met that day, by the way, both dead, and the doctor, who was someone we knew, who came to our conference, Martin, dead. And, you know, and this is all unfolding, I thought, and I was telling, you know, a lot of people here are friends of mine, in slow motion. And let me just say, the biggest problem we had was getting resources to implementation. And implementation, it's not rocket science, right? If it's staff, stuff, space, and systems, you need cash for all four of those things. And you need it quickly if you're going to respond to an epidemic. And if you're going to do it in a way that's going to strengthen the public sector, again, our advice to our poor, you know, friends from Europe who we said, go into the public hospital, go into the public clinics, go into the public sector, even though you're an NGO. They did, yeah. And some of them paid, you know, the ultimate price for doing that, right? Because that's what was completely absent in my experience in those two countries. I haven't, and Guinea, I don't really know, is there is not a public health system, neither for surveillance nor for care delivery. And if you're an NGO or a NIH or a Wellcome Trust or Gates Foundation or a smallish organization like Partners Health, you can still work to strengthen the public sector because states confer the right to health care, not NGOs, not research institutions, not us. Anyway, so we said two criteria, cash out the door and the number of people hired. And I'm telling you, if I had said that out loud to the foundations or, you know, it almost had to be a secret because that was so, well, you know, what are your metrics? What are you going to do? How does this fit with our goals? How is this going to build a resilient, you know, that's another buzzword already, resilient. But, you know, if we'd said that out loud, that's going to be our two criteria because we know that can save lives and help stop the epidemic. If we just get more people on the job. And there was, as Victor said, this chaotic swirl, but there wasn't a lot of support for, you know, this unromantic work of implementation, of actually building the systems. Anyway, we knew that eventually, if we worked in the public sector and had those two criteria, that we would have someone on our team fall ill, some ones on our team fall ill. And it happened, you know, it happened 14 days ago. And, you know, for what I am hoping to come out of this, you know, experience, I share the optimism that Jeremy mentioned. There are young people here. That cannot shake our resolve to address these grotesque disparities on all these levels, research, training, service, or care delivery, good care delivery. Because if we let it shake our resolve, we won't go back into the public sector. We won't go back into harm's way. You know, we won't go taking on XDR, TB, whatever, right? And, or we won't go to places where non-communicable diseases are the problem, but are seen as dangerous. And that's what I would hope from CUGH, that this next generation gets our backs so we can get the backs of the people who we should have been able to save and would have been able to save if we had the staff, the space, the stuff, and the systems you need to do this work. Thank you.
Thank you, Paul. And for us to know that even before this catastrophe was laid upon the crisis of the health human resources deficit, there was only approximately one physician for every 50,000 people in the countries most affected. And now the more than 400 people who have been killed by the virus since it affected that area. Esther, vous êtes prochaine. What we haven't spoken about as much of, but what is core and what is central to many of the comments you've heard here, are the social determinants of health. And Esther Duflo is the co-director of the Poverty Action Lab at MIT, one of our sponsors. And Esther, we are really delighted that you're here to talk about one of the neglected areas of global health. Merci beaucoup.
Thank you very much. I should start by being very happy that we are neglected. I didn't know that, so that makes us valuable suddenly. Let me start by putting a caveat. I feel very much like an imposter in this group, probably in this entire room. I'm not really a health person. I'm not even a health economist, so I haven't done anything really significant to save anybody's life. And I think I'm standing in for Larry Summers, which I don't look like at all in any way. So I hope you'll give me, I apologize for all these things. With that in mind, I want to rebound on the notion of failures, and in particular on the notion of failures of big ideas or on the failures of good ideas. And I want to put forward the motion that from where I sit, one of the problems that I see with global health is that too many people, too many of us, and maybe also too many policymakers in the South and in the North, think that they know what the biggest problem of global health is and think that they know the solution to that problem. I'm not going to talk about situations like the Ebola crisis or epidemics like that because I really know nothing about that. I want to talk about I want you to keep in mind, in a sense, the problem of universalizing the notion of progressive global health for everything and think of it as a delivery issue. I think there are products and technologies that we don't have and we should have. Some of them were alluded to. But there are also but we also have many products and technology that we do have, we know work, we've known have worked for a very long time. Oral rehydration solution is the typical example that people give, but there are many others of that kind. And those products and services, they are cheap, they could be delivered, there is no need for any deep freezers for them, and they're not delivered. They are not delivered in a consistent way, or they really, frankly, are not delivered at all. And the notion of, how is it that the world at large, in part, is not able to ensure access of the poorest of the poor to basic technologies that have been around forever, seems to me an absolutely fundamental issue. And that's an issue of delivery, that's an issue of organization, that's an issue of understanding how people behave, both people inside the system and people who are the beneficiaries or supposedly the beneficiary of the system that they don't really benefit from. And for that, many people have ideas. And there are many ideas floating around. Some of these ideas are very generous, some of them are less generous. Many of these ideas are, at least on a priori grounds, perfectly sensible. Some of them involve giving everything for free. Some of them involve giving nothing for free, including goods that have high externalities, spillovers, etc., and may be expensive because you make the argument that maybe it's not good, whatever. I'm not going to get into the detail of that. I pointed these two examples just to say that reasonable people make completely opposite arguments, sometimes within the same ministry at the same time. You will have very high incentive for one particular behavior, the effectiveness of which are not particularly been established, and at the same time absolute refusal to offer something for free that the effectiveness of which has been established, just because on the one hand you're convinced yourself that giving things for free is not good, and on the other hand you've convinced yourself that you need to incentivize people to do behavior. So people have these very strong views that are kind of clashing, collapsing, creating, a country that I know very well is India, as a completely incoherent public health system because of the clashes of these ideas. One very common thing about these ideas is they've not really been tested, that people are so attached to them that there is no effort to go in the field, try things out, take lessons from them, and decide what to do next. It's not about cost effectiveness at this point, it's just about effectiveness. My point is that common sense is rarely sufficient. Common sense will give you some good idea to get started, but it's not going to be sufficient for you to keep in mind everything else that you might have forgotten about why this idea may or may not work. It's very similar to the ideas when you have a new drug, there are lots of side effects, so you're keeping attention to one side of the molecule. The molecule is much bigger than what you thought about. So it is surprising to me, sitting from outside, that it is in global health that we're seeming to have such a strong power of these ideas or ideologies, to the extent of refusal to test basic things, try things out, innovate, move back, fail, but fail fast, and so that we have like a better functioning systems. Because, after all, this is a field that at large, medicine is driven by evidence. It's been very successful at generating a lot of new innovation based on trying things out and letting them fail and trying again until things were developed. We do that or you guys do that, for medicines or for technologies routinely. We have the technology and the tools to do the same thing for processes and for policies and for approaches, and it's underused. So that's my solution. It's not very original from where I sit. I think we should do more experimenting. Of course, in my mind, that involves more randomized controlled trials, but not only. It's really mainly about having the open-mindedness of trying things out before you get so enamored with them that they become nationwide policy. Preferably a very different nationwide policy than the one that was implemented by the guy before you, because new things have some value. I'll give you two examples of failures that I was personally involved with, because maybe it's, in this front of big room, pointing out two failures of mine will maybe resonate that I'm not trying to blame anybody. To tell you how important it is to test things out. So the first one is a project I've been involved with on indoor air pollution. Indoor air pollution is not a neglected disease, I don't think, but it's a big problem. A lot of people suffer from, in developing countries, cook with biofuel in very poorly ventilated areas, so there's the level of smoke that is in a house is really huge, and it's not good for anybody, particularly for the women who cook and the kids who are around with them. And there's plenty of evidence that it's bad for them. Okay, logically, the solution for this problem seems pretty basic. You could leapfrog and say, well, let's try to get people to abandon biofuel, but it's not really what people have insisted on. What people have tried is to say, let's try to improve the stoves that people work with by putting a chimney so that the bad stuff goes away. Of course, the problem is it goes away not very far, but let's forget that for a moment, but the bad stuff goes away from the room, and the indoor air pollution will diminish, and it should be good for people. So I found out about this. I found out about indoor air pollution being a big problem, about this technology. It sounded so obvious to me that it was going to improve health, that I decided with some collaborators and a big NGOs in India to do a project where we would look at the economic impact of having these devices in your home, this technology in your home, and therefore not being subject to the indoor air pollution. There was no doubt in my mind, and it's actually not such a frequent occurrence because generally I'm full of doubt. there was no doubt in my mind, based on all the literature I read, and any number of Nature and Science and Lancet and whatnot papers, that indoor air pollution was going to go away by putting the stoves. So fine, we go around, figure out, try to measure the pollution, blah, blah, blah. Get going with the experiments. We were working with an excellent NGO in Orissa, and they had done a program of stoves delivery some 20 years back. It had been a huge failure. People had abandoned the stoves, etc. So they were very cautious this time around. They decided to have a very good system to follow, that people really pay attention to the stove. There was a rapid response to fix the stove, etc. The research assistant on the project knew every single stove by first name. And off we went. And okay, the first 6 months were fine. We were measuring carbon monoxide in people's lungs, and it was going down. So we were happy, although we had a lot of stoves problems, but we were fixing them. And after the first 6 months, it was a string of disaster. The stoves broke, people didn't call, they just stopped. Even people who had functioning stoves stopped using them. And very quickly, no one was using the stoves anymore. No one was calling them to get them fixed. When we continued to measure carbon monoxide in people's lungs, there was absolutely no improvement. So of course, there was no improvement in health either down the line. We stuck with the project for 3 years and run around our poor stoves for all this time, and basically it shows that it didn't work. And what was the problem there? Well, the problem is something that in hindsight I should have known. The demand for the stove is very low. People are not, I don't exactly know why. It's something that we need to understand better, but it is not, people do not fully understand maybe the biology of it. For people it's not a priority. This particular stove didn't improve the energy consumption. So it's slightly more complicated to use them than a normal stove, so people there was no demand for them, so they didn't work. So that doesn't mean indoor air pollution is not a problem. It means that the stoves were a problem. The reason I'm pointing out is that maybe this particular model of stove was the wrong one. The point is that that's the one that at the time everybody was pushing. So now, of course, everybody pushes another kind of stoves and tells me that there is no problem with that stove. But the truth is that, to my knowledge, there is still no evidence showing that people stick to the stoves or to this kind of improved stove when you're given them. Even solar has the same issue, that they are not necessarily maintained. So, and still, there is an organization whose goal is to deliver 120 million of those stoves to the world, before we know whether the world wants them and how to structure it such that the world wants them. So that is that is the example I wanted to point out. It's been, I've been, in bad taste, I've been burned in that project because it was a lot of effort for something that was not really useful, but I think it's maybe useful to keep in mind. I do have some success stories of things that do work, but I'm going to keep them for maybe question and answer.
Merci, Esther. Glenda, I'm going to ask you the first question, and Jerry and I are going to play good cop, bad cop. You make the decision as to who's who, because you're the only person on this panel who doesn't live in a high-income country. We've heard a lot today about stuff, we've heard a lot about systems, but if you're the finest surgeon in the world, you need water, you need electricity, you need an infrastructure that's required. And where this doesn't occur, these are political failures. Can you share with us how academia can work more effectively with your institutions to be able to build, create, sustain, and retain the infrastructure, the people, the stuff, and such that's required to be able to address the challenges you see?
Yeah, we were having this discussion at tea about health systems, and so although in South Africa we train a lot of doctors and nurses and who are very capable and competent, when you put them into the health system, they face a health system where there's stockouts, the health system runs out of oxygen, runs out of, we have electrification issues, runs out of power, and how do you manage competent doctors and nurses manage health delivery in a situation where they're compromised by the fact that there's no drugs, there's no equipment, and there's no energy. And our problems may not be as great as in Freetown, but if you ask any health minister in Africa, what is his greatest problem? It's the health system. And so how do we improve the infrastructure and the administration of health systems to make sure that the competent doctors and nurses we do train can deliver the care that you required? So I'm not giving you a solution. I'm painting the picture that doctors and nurses face in Africa as they try and address the issue of healthcare. And surgery is one of the greatest problems, our ability to deliver surgery in Africa, be it hip replacement surgery or acute surgery or surgery for cancer. And so how do you scale up surgery in Africa, and how do you scale up infrastructure and equipment? How do we get forecasting so we don't have stockouts right? How do we manage the queues at the clinic? How do we triage patients? What are the systems, what are the innovations that we require in these settings? In order to try and address some of the triage problems we have in South Africa, we've developed a mobile app. So often when you go to a clinic in South Africa or in Africa, it's first come, first serve. And no one is triaging the urgent patients. So if you arrived with a myocardial infarct, and if you didn't, the nurse or the nurse assistant may do the blood pressure, heart rate, and respiratory rate, and may not put it all together. And if you had certain apps that could do that for you, that you could enter in the vital statistics, and then they could triage, we could maybe treat the person with a myocardial infarct faster than we treat someone with a chronic headache. And so the solutions are multifactorial, and as what my colleague here said, Esther said, there is a lot of stuff that does work that we don't know how to translate into action. So we have clinical guidelines coming out of our ears. We know how to do neonatal resuscitation, and we know how to treat hypertension, but we just are unable to translate clinical guidelines into action. And one of the vexing things is why can't we translate the stuff that we know into action? And that's another philosophical question around our human resources and our human resources in the healthcare setting, and how we train nurses and doctors to deliver healthcare in Africa. So I'm not going to give you any solutions, just more problems.
Esther, just one very brief comment, and maybe as a rationale for MIT to become more engaged in CUGH in the future. At one of the sessions here, I don't remember who it was, but they were talking about stoves. And the issue about the failure of the stoves was that the food didn't taste as good when you use these new stoves. So there are all sorts of insights, and maybe next year MIT will be more engaged and involved. We could use you. Tom, the first question, if you just state your name and institution, and for all of the questionnaires. Can we get the microphone on back here?
Oh, okay. Now, Tom Hall, UCSF. I'd like to highlight a blue whale that is in the room, and I have not heard any reference to the blue whale, which is, as you know, is far greater than the elephant. Not heard anything from the panel about the big issues, or indeed from this conference, and that is what relevance our institutions and our global health workers have for slowing population growth. And I'd like to note that in the next, by 2050, we're expecting to have about another 3 billion population. A high percentage of these babies will not planned. A very substantial percentage are not wanted, not desired, have profound impact on families, on women, and certainly on the fight against poverty. And almost 100%, the statistics are appalling, almost 100% in the least developed, poorest countries. We're looking to doubling or tripling population in Pakistan, Ethiopia, the Sahelian countries, Uganda, Kenya, Philippines. And of course, all of this accommodating this population, complicated by global warming, climate change, and so forth. And sadly, since the 1994 conference in Cairo, population issues have just gone under the radar, seldom get mentioned in any of the venues we have. I'd like to compliment the UK, as the Parliament commissioned a special report on the population dimension in the attempt to achieve the MDGs. And I'd like to compliment Julio, Mexico. When I was working in population in 1970, Mexican population was projected within 80 years to exceed 800 billion. And Mexico took leadership in 1973 to adjust that. But many other countries are not doing it. So a blue whale is in the room.
Any comments?
Well, since Mexico was mentioned, I will say the following. I agree with Tom on the diagnosis. However, the implication that you deal with that as a separate issue, I think the history is that you need to work on the demand side, and the demand side is hugely motivated by the success in lowering infant mortality. And the Mexico success story, and Mexico is rapidly approaching replacement fertility, is that infant mortality dropped enormously. That then creates a demand, and then you need an effective health system that is able to provide the contraceptives and empower women, mostly women, to control their own reproductive lives. But it doesn't happen in the absence of a major improvement. Now, for a lot of people, that's counterintuitive, because obviously if you save more children, the population grows even more. That is true. However, it's the only sustainable strategy, and all the lessons are that everywhere where fertility has dropped, it was preceded by a major drop in infant mortality. And if we need to do the two sides. I don't think this is an either or. We need to persevere in assuring the survival and the quality of life of surviving children, and at the same time work on the supply side. That will create a demand. We need to empower women. That's also a demand side intervention. For example, through conditional cash transfers that put control over resources in women. And then you need to have an effective health system that will then satisfy the demand for effective contraceptive technology. But if you don't work on the two sides of that equation, it's not a sustainable solution.
Yeah, I'll just add one comment. I think there's a series published in Lancet in 2013 about Bangladesh, which sits right next to two of the countries that have not solved the problem that you alluded to. In Bangladesh, its birth rate is now at 2.3, right? I mean, that is not much different than this country. And it's poorer than either India or China by a significant measure, but it has undertaken some of the things that Julio just alluded to, right? Empowering women, a very interesting mix of NGO and governmental agencies, and making birth control widely available and addressing under 5 mortality. And they're right down there with any other major developing country at 2.3 right now.
Well, I mean, of course, I'm struck by the fact that we're talking about women's empowerment, and here a third guy says something on the panel. But because we know that women's empowerment and education and agency freedom, as Amartya Sen says, these are some things that you're calling demand side. How crass of you, Julio. But I just want to go back to this this idea of dangerous ideas or big ideas that weren't true. And I think it'd be better to say them, because the population control field, its academic side and its implementation side in big agencies, said, you know, if we don't control population through modern contraception, you know, mortality of children is going to go through the roof and the world's going to explode and we're all going to die. Well, that's not what happened. That's not at all what happened. You know, the grand convergence shows that, in fact, the opposite happened. That as child survival and women's empowerment increased, then, in fact, the size of those families increased. And, you know, it's one of those, what Esther was talking about, you know, when we say, you know, we should say that was false. We made a mistake, you know, well, I wasn't born then, but, you know, and my mother definitely did not follow the recommendations of the population control people. But you know, I think that's an example of a big idea that, you know, needs to be rejected.
I'll add something just for the women empowerment sake. India is a place which still pays the cost for the population control attempt. During the emergency way back when, there was really an effort to sterilize a lot of people against their will. A big reason why, a contributing factor to the pretty disastrous state of basic public health in India today is that people just don't trust it at all. So people do not want to set foot in sub-centers. They don't want to set foot in sub-centers because they are worried that the nurse is going to try and convince them to get sterilized. And I thought it was just like lingering memories, but it is still the case, that there is still a lot of pressure for nurses to deliver some amount of quotas for women's sterilization. Guess what? Most people have no desire to get sterilized. And that, I think that has an enormous feedback effect on the entire system, in particular on things like immunization, simply because people are in prenatal care, because people do not want to get anywhere close to a nurse who might say, oh, by the way, would you get sterilized? So I think it is very, so that's one thing. The other thing is that, so there is less research than I would hope on the impact of even contraceptive availability on fertility, but the example of very successful countries that have done this successfully historically, for example, Colombia, suggests that the effect of contraceptives alone, contraceptive availability alone, is very small. That compared to the demand factors, the child mortality is one of them, but the reason that I wanted to take it is to broaden it a little bit. People are very sophisticated in their decision to have children. And the child is like a savings policy and health insurance and an old age policy all rolled into one nice little bundle. And of course, if the child is more likely to survive, that makes each of the child more attractive, you're less likely to want that many. But also, if there are other ways to ensure your security, for example, the economy is growing. This is something that is happening in Bangladesh. So you're thinking that your future is brighter than it is, and there are savings options, and there are old age security options in place. That has actually a very large impact on the number of children families have. So taking into account the broader demand side, not just child mortality, although that's definitely one of them, is pretty key.
Professor Farrar, did you want to speak to it? Or let's go back over here.
Is this on?
Yes.
Hi, my name is Salimata Bengora. I am originally from Mali, but I grew up here in the United States. I'm currently the program manager at the University of Massachusetts Medical School, Ebola relief work in Liberia. When Ebola hit, the African diaspora community in Worcester mobilized to raise awareness and funding for their families and friends that were dying back home in Liberia and West Africa. And fortunately, UMass Medical School was able to provide a platform to engage them and get them involved. This experience made me realize the depth of lack of opportunity available to the African diaspora to engage us when it comes to topics involving health in Africa, the health of our families and friends who are affected by the programs that we talk about. And my question is there anything being done to better engage the diaspora? Because I think it's a big missed opportunity because we are the future and we have lived in both worlds and we are interested here in improving our knowledge base in different sectors and to bring that knowledge back home coupled with what we already know about our countries. Is there anything being done? And if not, I implore you to please include us in the big ideas and the future of Africa and the millions of lives that are affected by the programs that we are going to bring. Thank you.
Thank you for those comments. Actually, I met with your Chancellor Collins the other day, and I became aware of the great work that UMass and others are doing. Part of what I'm trying to do is to listen to all of you with great suggestions so that as we go forward with our planning, that we actually include the essential stakeholders. And certainly I think that what you point out is very important in our planning. We have, in fact, engaged in our earlier conversation with some of the people who, in fact, the diaspora from Africa, but we intend to go forward doing that. Thank you.
We'll go down here in front. It'll go on as you start to talk.
Okay. I'm Sharon Rudy. I'm with the Global Health Fellows Program, and I was going to make a comment about they're not wishing that there was an African woman on the, and then I realized Glenda was there, so hi, nice to see you. Although I have to say that I learned most of my global health work from Black African women. So my question is about a survey that we just did. We talked to 49 experienced global health program directors who had been recruiting from academia from 11 to 30 years, and 85% of those program directors said that academia could and should do a better job training in a certain area of competence. And that skill cluster includes collaboration, communication with clients and counterparts, team building, both being a team member and building teams. So that kind of arena, they feel that when they get really smart people from academia, really well trained in a lot of important areas, but that skill area is a crapshoot as to whether they were going to get somebody with sufficient emotional intelligence. They feel like it's a deal breaker in terms of the ability to do this work successfully. So I'd really like to get your opinion about how important you think that competency area is in the work, and whether academia can or should be a part of paying attention to that. Thanks.
Julio?
I had the privilege of co-chairing with Lincoln Chen a commission on the education of health professionals for the 21st century. And we very explicitly talk about exactly that sort of generic competencies. And now, as Dean of the Harvard T.H. Chan School of Public Health, we're implementing some of those ideas. And the vision is that we need to educate. By the way, I prefer the word educate to train, because train somehow sounds like it's what you do with your pet, or education is more than developing concrete, actionable skills. And I use the word competency in that broad sense, not just discrete skills. And it refers exactly to what you're saying. The model or the vision we're having is we need to educate T-shaped, like the letter T, individuals. Right now we educate I-shaped, people who are very deep in one specific area. That's how we end up siloing the various areas. And we need to construct the horizontal part of the T and develop those cross-cutting competencies, among which the ones you've pointed out are absolutely critical. The competencies to communicate persuasively, to collaborate and to understand other disciplinary perspectives and other organizational perspectives, because we're educating leaders who are going to be interacting with people who are not all of whom went to university, or to interact with community health workers, to really develop not just interdisciplinary, but transdisciplinary, trans-professional practice and team building, a lot of the competencies that form the horizontal, integrative, cross-cutting competencies. And that ought to be part of the curricular design. So it's a very important question. We don't have time for more details, but I think it is crucial, and I think we, schools and universities, need to get serious about the cross-cutting competencies.
Can I just, because I'm sitting next to him, I can take the mic. You know, there's just, you know, I think there's another part of that is to also, again, getting back to this sociology of ideas and the looking for failure and errors, that the idea of cultural competency is one of those errors. It takes decades to develop cultural competency in another place, right? I mean, an anthropologist, the old school, 2 years of field work, you know, fluency in the language, understanding how kinship works, trade, commerce, blah, blah, blah. But we do need cultural humility, right? That's what, and this gets back to the diaspora question. Like, anybody can come in and say, oh, we've got the magic bullet or the stove or whatever, but one of the biggest problems that we've seen, and you know, again, I'm not saying in others, in ourselves, is over the last 30 years, especially in crises, is a lack of humility and a lack of cultural humility, you know, which just says, I don't know this place. It will take me many years to know this place. There are things that we would like to be part of in a very short term, right? Meaning months or years as opposed to decades. And, you know, to cultivate that in universities is to go against the grain of the university. And so let's go against the grain of the university. Let's say we're not welcome. You know, who better than CUGH to say universities are not welcome in these settings unless they are there as real partners with humility and with an understanding that they have resources, you know, because they come from well-to-do places, including the diaspora, right? It's just like, you know, after the earthquake in Haiti, that friction, which Victor saw with me, between diaspora Haitians and the Haitians who were left behind, was very profound, in part because of a lack of humility. And it wasn't from the Haitians community health workers or it was families who were there during the earthquake. So, and it's even worse from universities, of course. So cultivating that as part of a core competency, I think, is really important.
Thanks, Paul.
I'm Andrew Haig from the University of Michigan. You know, I'm sitting at my first meeting here of 1,700 optimists, and it's pretty cool. And seeing you guys up there who are really the big thinkers is also great. And I consider myself among you optimists, but I forgot to take my Prozac today. And I'm looking at each of your careers and saying, each of you actually think you're going to succeed. And many of you will. But as a group, we have failed. And as a group, I can predict that we will continue to fail. We will have people disabled and dead as far as I can see in the future. Most people that you think you can fix, we look at 20, 30% decrease in diabetes. What about the others? So the dead people, I don't know what to do with them in terms of health. I just haven't gotten that good. The disabled people, there is an overwhelming literature on the effect of medical rehabilitation for that population. Now, I'm not here to say that rehab should take over all of the priorities, not even a bit. But as I looked around the meeting today, I saw almost no consideration of failure. I saw prevention, and I saw acute medicine, and I didn't say, what do we do with the 18% of any society that lives and consumes but doesn't contribute optimally to society? So it's a small part of the big picture for sure, but I'd love some comments on how you weigh that priority. Thanks.
Briefly, because I see there are many people who want to participate. You know, we need to good health systems approach the entire cycle of care, the whole arc of care, and that certainly includes questions like rehabilitation. There's a huge issue now on, and Paul and I are on yet another commission on the questions of survivorship and pain control and palliation. Probably the single largest or the most inequitably distributed variable in the entire world is access to effective pain control. It's a huge element of a fundamental human right to avoid avoidable pain and suffering. It doesn't show up in cost effectiveness analysis. It's not cost effective because those people are going to die. But how you die is also a fundamental part. So we don't have time to go into more detail, but I think we have to have comprehensive systems that don't just operate in the prevention and initial treatment, but actually take into account that people increasingly live increasingly longer periods of their lives with less than perfect health, and that providing solutions for that is also part of a well-performing health system.
We'll go to the front here. We're also running out of time, so probably just going to be able to take 2 more, and it'll be from here and here. So we go to you first. Sorry.
Hi, thank you so much for being here and sharing your insights. My name is Ishan. I'm an undergraduate at Harvard. The theme of this year's conference, as you mentioned, Dean Frenk, is mobilizing research for global health. And I think as university affiliates, a lot of us here in this room appreciate the importance of research in global health, both in terms of defining the gaps, but also creating the evidence base for the interventions that we have and the tools that we have in global health. So my question is actually on the flip side, namely when there is not enough research or evidence. I think I've come to appreciate through my studies so far that oftentimes a lack or scarcity of research or evidence in particular populations is often used as an excuse for inaction. And I think that is particularly true in settings where research is scarce, in settings of poverty. And so I was wondering, as individuals whose careers have spanned both the research component, but also the implementation and the delivery and the policy components of global health, to what extent do you believe this issue of inaction on the basis of scarcity of research is an issue and an impediment to the future of global health equity? Thank you.
Yeah, I think you raise a very, very important question. And there's not so many countries around the world, in all honesty, that want to use scientific evidence in the way they formulate policies, and that's a gap. The number of politicians around the world who come with a science background is limited, and the number of politicians willing to use the evidence to make good policies, I think, is also sadly limited. I think the health community as well has traditionally worked too narrow within the spectrum of political thinking. It's tended to work with ministries of health alone, and I think on the whole, ministries of health around the world are relatively weak, often within the cabinet and other government structures. And I think the health community's got to think beyond its own narrow spectrum of areas of influence in order to bring about the changes of policies and practice that would lead to better health. I think the last thing I'll say is that what you talk about, I think, would be helped, and it comes back to the diaspora point, by those of us who are in a position to influence by shifting the center of gravity of where decisions are made about what research is done from places like Washington or London or Geneva to the places that really matter. And I'd put a challenge back to my colleague on the left to say we would not just accept £1 to £1, we'd accept half a round to £1 and join us, along with the Bill and Melinda Gates Foundation, in pushing the peer review and process of decision making about which grants are given away from London and Seattle, and establishing this through the African Academy of Sciences in Africa, where the decisions will be made about how and what research is done. So you'd be very welcome to join us in that at half a rand to £1. We've put in £40 million, that's $60 million. Gates Foundation is coming into the African Academy of Sciences, and you could come in at half a rand to £1.
As long as it comes to my institution. No, that's a great idea. So I think it's important in terms of burden of disease is to understand the rarity or the scarcity of knowledge of certain diseases in certain populations. And that is why it's important to try and understand what's coming down the pike. For instance, because we've had such a low life expectancy, we don't know what the burden of Alzheimer's is in Black South Africans. And so as we increase life expectancy, we should be starting to know and turn our attention to the diseases that we have not yet documented or understood. And that's a very important thing.
So just for a minute, and I spent almost 18 years as a member of Parliament in Canada, and one of the heartbreaking situations I saw and as a physician, on one hand, seeing this extraordinary body of knowledge that is produced, and this huge chasm between what is understood by those who are making policy, because they're not scientists, and the public that also doesn't understand much of what we deal with on a day-to-day basis. So this is actually a plea to everybody in this room. You have the knowledge, you have the power, and you have the ability to communicate not only to the politicians, but for heaven's sakes, please speak to the public, because the public moves the political, often, not always, but if we don't do that, if you don't build up a public constituency, if you don't educate the public of what we need to do, why we need to do it, for everybody's benefit, then you're not going to move the politicians, because they're interested in being reelected. So as a plea for me as a reforming politician, please, let's all do that. Work with your colleagues, work with the public, and in that way, we can have an impact.
Yeah, I just want to say a word that I'm totally in agreement, because I'm in Washington now, and having pursued an academic career, I'm at the IOM. And actually, most of what we do is, in fact, informing policy using evidence base. And the fact is that after we've finished our reports, have great recommendation, there's still a gap of adoption. And that adoption is very much dependent on, indeed, what Keith has said. That is that the political will of moving things forward. So I appreciate many of the things that's been said. For example, we just finished an extensive report on end-of-life care, which has really mobilized the nation, if we will, to look at this, including senators, to say, let's change policy and legislation. It's the part of a continuum of care. We have multiple studies on interprofessional education, and in fact, what is the quality and what is the competencies that need to be taught. So I just want to say that it does engage people like yourself to go into policy. A lot of Paul and I have been for many years into implementation, but I think that you need policy to go along with the ability to implement that can really make a difference. And so we're looking for people interested in actually taking your great passion and your great idea and to really do evidence-based advice to the government.
So we'll take just two more, I'm afraid, here, and then last question here. The gentleman back there, I'm sorry, we won't be able to get to you.
Hi, my name is Linda. I have a background in population and family health. And my question actually relates more to Ebola and a supply chain question in health education. I had the pleasure of hearing Masuku Ufala speak at Harvard. He's a Harvard grad about Ebola response by Liberia. And one of his comments that was surprising to me, and maybe not when I think back to population and family health and supply chains for condom distribution, was that there was a stock out in glove supplies, whether those be latex glove or nitrile gloves. And I wanted to know, perhaps Dr. Farrar can speak to this or others, about, to me, the concept here is big problems, big ideas. I think this might be an old problem, and we need a big and more innovative idea about how to not have stock out supplies of basic medical supplies such as gloves and other more advanced items. I'd like to hear your response. Thanks.
Thank you. I mean, you've just diagnosed the problem that anyone working can see, even in a relatively affluent nation from the point of view of Guinea, Sierra Leone, Liberia. But I mean, we live in a global political economy, right? And there are companies and institutions that have redundant supplies to prevent stockouts. There's a reason that no one who reached one of our hospitals in Boston after the marathon bombing died, because there's like system backup after backup, and that's a public good issue. I'm not going to go back to Coca-Cola or DHL. But when I want to, so there's no question that this could be avoided, but the irony and the unfairness is worse since, after all, Liberia is the site of the largest latex rubber plantations in the world at some time, and after World War II, there's a little bit of Liberian rubber in every tire, for every car. So even though we've forgotten that, I don't think the Liberians have forgotten it. And back to Esther's point about, why would people not trust the healthcare system? Because it does things to them that they don't want, because it is of poor quality, because there are stockouts, especially, as I said, in the public sector. So all this not to sound like I'm just adding another, dismal assessment. It's just that clearly these are readily addressed with the, again, right staff, space, and systems. There's no reason that they have to persist in that way. And as far as family planning goes, there's now been stockouts of, every method imaginable as the health system, such as it was, collapsed. And one thing that'd be worth doing is looking back at from the end of the war, which didn't get mentioned, the civil wars in that region. That's been over a decade, and billions of dollars have been invested in, building or rebuilding institutions, public health and public education. So we also need to understand, why didn't that work better? And again, this is not a rhetorical question, it's an empirical question. And if you look, you'll see that very little of those resources were invested through Liberian institutions or Sierra Leonean institutions, but rather through standalone and NGOs, for example, or contractors that it wasn't their goal to strengthen those institutions so much as to meet some quota or a metric that did not include these very simple metrics. How many employees, Liberian, for example, how does this strengthen Liberian capacity, including in research? There are plenty of Liberian researchers out there waiting to get trained, like our students are.
I just want to point out that, in fact, part of the framework we're working on is to address that issue per se. How do you mobilize these things, countermeasures, et cetera? That has to be part of the solution. So we're going to be tackling that issue and hopefully straight on. I also want to point out that every one of you can make a difference. I'm looking at Dr. Hagelin here at Duke, and he's the one who, in fact, convinced Duke Health System to give away tons of equipment that actually helped him build a neurosurgery program in Uganda. Every one of you in every institution, if people are willing to volunteer and give a lot of resources to it, in this case, surgical equipment, you can also make a difference. I know it's a smaller issue, but I think it is the passion that you can bring to the table.
Last question here.
Hi, Quentin Eichmann, Vanderbilt University. We've partly talked about competencies, and we need a new set of competencies. In the Lancet document of 2010, there's clearly a landmark document, but I'm concerned about the way medical education is going more tangibly in Africa, with all the new medical schools opening, and then we have the MEPI initiative. Now, I'm curious to know whether we can think more specifically, also in light of what we've been hearing about the balkanization of education and siloed disciplines. Are we doing enough? Or how should we be thinking differently, paradigmatically, about educating a new generation of physicians? Because I'm worried that what we're doing is importing the same old curricula back into Africa, educating in the same kind of framework all over again. And I'm curious for new kind of paradigms as to how we should be doing this, because we're going to be committing the same kind of errors all over again.
People like Craig Wilson and Roger Glass should comment on some of the innovation that they are working in trying to look at new ways of training medical students in new medical schools in Africa. And Roger or Craig, I think you'd probably be the best people to answer, because you're doing exactly that if you're in the audience still. Roger, where's Roger? He's gone.
But while we're waiting for Roger...
Or Craig Wilson.
Anyway, Julio wanted to...
In the Lancet report, we actually see the opportunity of building new medical schools as exactly the equivalent of leapfrogging into a new generation of strategies for education. And I would have had exactly the same idea if Roger was here, but I do think MEPI very deliberately is trying to create those partnerships and leapfrog, not just replicate the model that we are trying to now reform in older institutions like here at Harvard. So now there's been a lot of innovation, by the way, in medical school. I think the movement around problem-centered or problem-oriented medical education, now that we just recently lost John Evans, a true giant who founded the McMaster School and inaugurated an era in the 1970s around innovation. So I do think we've built up a progressive movement away from the original Flexnerial paradigm. But for the 21st century, we need to go further. And one of the strong ideas, and I think it's very relevant for an organization like CUGH, is the notion of building global consortia of institutions to generate innovative models and to help strengthen capacity both in poor countries but also in rich countries that need the qualitative re-energizing, repowering that comes from partnering with institutions in poorer parts of the world. It's not a paternalistic approach that we are going to, educate you and build your capacity. I think that's a very outmoded model. But it's partnering, and I do think the new technological platforms offer an unprecedented opportunity because we now do have the opportunity of building platforms for engaged learning, active, interactive, and personalized education, and build consortia around the world. There's no way that all 194 member states by itself is going to educate its entire complement of required health professionals by itself, and it doesn't need to be like that. If we find and build consortia based on mutual accountability, mutual benefit, so the US and Europe and Australia-based institutions need also to benefit from those partnerships, then I think we can actually move into a very different institutional space for the education of the next generation of health professionals.
Sadly, I think it's time that we close the session. Just one comment before we give these folks a big round of applause. When our organizing committee thought about this session, the concern was we would never attract people like this group to come for 10 minutes of glory at CUGH. But come they did, and I think it was absolutely spectacular. So a big round of applause.